So as far as treatment options for testosterone replacement, we all know everything that's out there, but just to review it, the oral supplements. And in this, we're also categorizing what you hear advertised that's not directly testosterone, but this will increase your testosterone. And I have to say that there isn't much out there that shows any efficacy scientifically for any of these things to really work. But as far as oral supplementation of actual testosterone, that really isn't used that much. We'll talk about it in a little bit, but it has a very high level of hepatotoxicity. There are injections, patches, gels, and pellets. So as I mentioned, the oral over-the-counter preparations are not considered to be really efficacious. Have we had patients say, oh, it really works? Yeah, I've had a lot of patients say, oh, I came in, I bought some new mail or whatever they did, I'm ready to go. Placebo effect? I don't know. Maybe not enough studies have been done. But you will have some patients who will tell you that they do work, but the evidence isn't there. The only oral testosterone that's still available to my knowledge is the methyltestosterone. But again, not really used, probably should not be used because of the problems to the liver. There is a testosterone undecanoate, but not the injectable form, an oral form. But that was rejected by the FDA because they figured that it would be ripe for misuse. Now there is also a phase 2 trial of a TSX200. Has anybody heard of that before? It's an oral preparation of testosterone, of actual testosterone, and it looks like it's very good in these studies, all right? And the good thing about it is that it's actually absorbed in the intestine. So it bypasses the liver metabolism, so you don't have to worry about the hepatotoxicity. Now, as far as intramuscular therapy, the short-acting is the cypionate or the enanthanate, and usually that's given every 1 to 2 weeks, but it could be even longer than that. It may result in the supraphysiologic levels, with wide peaks and troughs, and those can exacerbate the symptoms. So you have to make sure that they're on a schedule that will give them more a gonadal level of the testosterone. The long-acting, the testosterone undecanoate, Avid is the name of it. I've never used it, but it's given every 10 weeks. And the early dose, though, is given just a month apart, the early 2 doses, and then every 10 weeks. It's a larger volume, and it's given in the office, because some of the other injections, the patient can be taught to give them at home. The patient needs to stay in the office, or should stay in the office for about 30 minutes afterwards, because they're a concern about oil embolism, and he may become very short of breath after this injection, so he has to wait around for a bit. Has anybody used that? Have you had any problem with it? Okay. All right, and after the first time, do they wait, or do they wait every time? Always wait, okay. The VA never had that. And the patch therapy, this certainly has been very popular, and it's actually been in use, since 1994. And the first was a scrotal patch, the Testoderm, and then the non-scrotal patch, the Angioderm. There is also a buccal mucosal patch. It's a capsule that turns into a patch once you put it in the mucosa, and it attaches to the inside of the mouth. But that needs to be changed every 12 hours, so twice a day. But the patches, the good thing about them is the daily dosing allows for a very even exchange a very even level, a fairly even level of testosterone. So unlike the injections where you can have a peak and then you have a trough, so you can have symptoms that are doing well and then not so well. And if it goes too high, then you may even have more aggressive behavior. Although aggression with testosterone replacement usually doesn't happen. You don't have the roid rage unless you see really supra levels, like about 115. So that's what the literature says. So the transdermal and gel solutions, this is the most common form right now. So it's used about 2/3, about 72% of people who receive testosterone replacement use one of these. So it does allow for dose titration, and that's the good thing. And you have androgel, you have 2 levels of them. You have Testim, Foresta, the Axiron. And the reason why the Foresta was developed is because of the FDA warning of the transference of the gel to either children or women. So if you come in close skin contact of someone who put that on, then you can pick that up as well. So the Foresta was developed because that's put on the inner thigh, and they figured there's less likelihood of close contact with another person at that time. And the Axiron is to the axilla, so it's a couple of pump sprays to the axilla, and you figure, well, not too many people are going to be rubbing against your underarm, I guess. Has anybody used the Axiron? Okay, good results with it? Yeah? Okay, good. All right, and then there's a nasal form, the Natesto, which was approved in 2014, and it must be applied 2 to 3 times a day. Anybody using that? That's pretty new. You had one patient, did it work for him?
It worked. It's hard to sell.
Right. I would think for both the nasal form and the oral, the mucosal form, oral mucosa, I don't know. To do it 2 to 3 times a day, 2 times a day is the most I can just take an oral pill. But then to actually do something other than that, you're not going to have a lot of patient adherence. And the implant therapy. The pellets were approved by the FDA in 2008. Testapel, the big brand name, is inserted into the fat pads of the lower back or the buttocks. Initially, maybe about 4 pellets, but adjusted to the patient's response and to the labs. So the problem with or a potential problem is that if there is an issue with it, then it's very difficult to remove them once they're in. Although it was approved in 2008, this was actually one of the first ways that testosterone replacement was tried, because they started trying this back in the 1940s. So it's one of the oldest ways of replacing testosterone, but it wasn't in general use. So what we have here is a typical dosing for the different ones. The testosterone, the most common one that I worked with was 200 or 400 milligrams IM with the injections. But there were people who were doing it every week at home, so things like that. You can adjust it, you can really curtail it to that particular person. And then the patch, all the usual dosages are up there. The TRT evaluation for formula-specific adverse events. So it depends upon how the preparation is done and what you're going to look for. So for the injectable, you ask them about mood swings because of the peak and troughs. So you ask them about fluctuation in their libido. Cough after injection. So not many, but some people develop a cough after the injection of testosterone. I have not seen that, when I was practicing. Have any of you seen that? Okay, so I saw 2 hands go up. So apparently it's not happening very often, but it's something that you may consider. The patch, you have to look for signs of skin irritation at the application site. So, in some of the patches and gels, same thing, may have a higher incidence of that happening. I know the Fortesta actually has what they say is a rate of up to 16% of skin irritation from it. So with the gels, you advise the patient to cover the area with clothing and wash the site before having skin-to-skin contact, again, to avoid the transference of the residue, which could still be active, to another person. And the buccal tablets, you do want to ask them about any alterations in their taste, because it could affect that. And also examine the gums, the oral mucosa, for any irritation there. Testosterone replacement is synergistic with the PDE5 inhibitors. But what I want to point out is once they are on TRT and their testosterone regains eugonadal level, then they should try having sex without the Viagras, because that may be all that they need. And then that would be one less medication for them to take. And if it doesn't work, then the 2 together are fine. All right, so as far as monitoring, once we have someone on replacement therapy, then you want to monitor. All right, so what we do is with the testosterone, the total testosterone, you want to check it out in 2 or 3 months. So with the testopole implants, though, you check it at 6 weeks, and that's because that's when it should be peaking, and then at 4 months, because that's when it should be at lowest. And that will help you determine what the next dose should be, how many pellets do they get. The PSA should be checked at least 1 extra time, unless they do have a history of prostate cancer or they have bad LUTs. If they have BPH symptoms, then check more often, so like every 3 months, at least 3 to 6 months. If it's stable and their symptoms are stable, then you can back off a little bit. Although with prostate cancer, I have not and did not, but we kept on checking every 3 to 6 months with their PSA. The CBC, you want a baseline, and then you want another one done in 3 to 6 months, and then annually if it's okay. And that's to ensure there's no polycythemia. Because if the hematocrit is over 50, then you should really stop the testosterone replacement. And as far as bone mineral density, you won't see any immediate change in that, so you should check it after 1 or 2 years on the TRT. If someone's doing fine, they don't have prostate cancer, they don't have bad LUTs, then no. After you check it like every, maybe the first 6 months, 3 months, and it's okay, then you don't need to check it every 3 to 6 months. You can just do it annually. Unless they're saying it's not working right, or their symptoms are increasing, that symptoms that were fine before, then I'd recheck it. But otherwise, no.
Excuse me, Kay, are you saying that you can give testosterone replacement for somebody with no prostate cancer?
Yes, that was something. Okay, I can say this because Mary's about the same age as I am, but it used to be religion that if someone had prostate cancer, they are not going to get testosterone. But that has changed. So if we have someone who has been successfully, as far as we can see, successfully treated for their prostate cancer, then we could go ahead and initiate the testosterone and then see how it does. Okay, but you want to check that PSA very regularly. And we'll talk about that a little further on. Okay, so a CBC, again, you want to do that as I said, every 3 to 6 months. If it's okay, then you can go back to every year or however often. Interesting. Okay, so they're not donating, I don't know if you heard all that, but they're not donating their blood, but they are doing phlebotomies so that their hematocrit will go down. Otherwise, if it is over 50, they should really stop the testosterone replacement. So the benefits and goals, because I've been kind of bad-mouthing testosterone replacement, I guess. So I don't want to do that. I just want to make it appropriate. So definitely it has a lot of good effects. And we all know what they are. So all those symptoms that they had with the low libido, with the erectile dysfunction, etc., the bone density, etc., etc. Unfortunately, most of our people who are looking for testosterone treatment, they're doing it only for the erectile dysfunction and low libido part of it. So they don't see the other benefits. So people who don't have or aren't bothered by the low libido or erectile dysfunction, but may benefit, may not be looking for it. Again, this is another patient education issue. It's also a matter of our assessment of our patients and who would benefit from the replacement therapy for low T. All right, we already covered some of these, the adverse effects of replacement therapy, the polycythemia, the gynecomastia can happen, alopecia, edema, the hepatotoxicity, the oily skin, and aggression. But like I said before, that roid rage usually occurs at very high levels. When you are replacing testosterone, your goal is to find that level of testosterone between 400 and 800. So if you really don't want it higher than that. And with a lot of men, we see improvement. I would have had a lot of patients with low 200s, mid 200s, and if we just got it up over 300, that even made a substantial difference in their functioning and how they felt. So you're not looking for any supraphysiological levels. You just want to keep it within a decent normal range. Now the risks, the things to consider. BPH, because the testosterone may lead to further prostatic enlargement. And in fact, studies have shown that it does increase prostate volume. That's mainly in the first 6 months of treatment, and then it levels off. Okay, so the other thing, though, is that even though it shows enlargement, there's now evidence that links the testosterone replacement to improved LUTs. Okay, so that's another side of the coin that we haven't looked at. We're concerned about worsening their LUTs, when in fact there are some studies that show that the elasticity of the prostate is increased and it actually helps their LUTs. Prostate cancer. Again, we talked a little bit about that. There's no clear evidence that testosterone replacement therapy increases the risk of developing prostate cancer. And we'll talk a little bit more about that. So there's no clear evidence. The key thing there is that we're saying, well, there's not any evidence. There's just no evidence that we have seen and it has been studied. And so far, we don't see any clear evidence. As far as fertility, well, testosterone replacement is not for the man who has fertility issues, because the testosterone replacement can actually cause the infertility to become worse or permanent. All right, because what you're doing when you're replacing the testosterone is you're shutting off that pituitary access. You're shutting all that gonadotrophin access out. And in some cases, that could actually become permanent. I don't think very many, but it has been mentioned in the literature that that could become permanent. So if someone is looking for testosterone because they're having fertility problems, it's not for them. Then as far as having an MI-CVA or DVT, this all goes back to the polycythemia issue. So you have to be cautious if someone who has a history of that, and you do have to monitor that CBC. Contraindications: untreated prostate or breast cancer. That's an absolute. Okay, so that's absolute. If there's untreated prostate or breast cancer, then testosterone is not for them. Suspicion of prostate cancer, okay, but if it's ruled out, then you can go ahead with it. So if they have a nodule, if their PSA is elevated, they can't start testosterone until that's checked out and prostate cancer is ruled out. We already talked about if the hematocrit is greater than 50, unstable congestive heart failure, and sleep apnea. Now that's a relative contraindication. There are people who have sleep apnea who do take testosterone, but definitely it's a relative contraindication. So you have to see very carefully, you have to monitor how they're doing, and I would think how bad their sleep apnea is to begin with. Now as far as replacement in prostate cancer, all right, so this is someone who, yes? For young men who have low testosterone? Well, what you want to do first is see what the cause of it is. Is there something that you can do to correct the cause of why they have low T? All right, and then if you have ruled out everything, then yes, you can consider it. Certainly there will be men there with it. You also will have men, and I had men coming to my clinic saying, asking for testosterone replacement, and really in questioning and examining and looking at all their lab values. I remember one, he was really kind of shamefaced because he had admitted he just wants it to, because it sounds like it would really enhance his performance. So he actually did shamefacedly admitted that. But yes, when there are real reasons for it and there's nothing that you can correct, you've already looked into if there are other causes and you can't correct them or you don't see other causes, you can try it. Absolutely. Okay. There is limited data for testosterone replacement in patients previously treated for localized prostate cancer. So the key word there is limited, but again, as I mentioned before, the evidence that we have so far says that it's okay. All right, but what you might want to keep in mind is that there may be a higher risk in patients who had radiation treatment versus surgery. So if they had a prostatectomy, they have a lower risk of it recurring with testosterone replacement. But if they had radiation, then they have a little higher risk of it recurring if you put them on TRT. So you do want to check that PSA every 3 months, okay, to be sure that that's not happening. And if the PSA goes up at all, then you stop the TRT. As far as cardiovascular risk, this was the biggest hullabaloo most recently with, well, prostate cancer is a pretty big one too, but I mean, that has been kind of very slowly been looked at. But in the last 3-4 years, the cardiovascular risk was out there, the problem with it. And here's the little timeline. So from 2013, a JAMA article wrote about the risk of it. That men who were taking TRT had a 30% higher risk of a cardiovascular event. So that in January 14th, the FDA issues an alert recommending caution. And then in June of 14, they issue a general warning against the possibility of DVTs or PEs. Then in September of 14, the FDA advisory panel concludes that there is no evidence of increased risk. But calls for more stringent guidelines in prescribing it. And basically the European panel that's about the same level came up with the same idea, the same conclusion. As far as testosterone replacement and lipid profile, we have inconsistent data on this. So if you restore the testosterone to eugonadal levels, then it does not result in any worsening of lipid profiles. Again, you want to stay away from those supraphysiologic numbers. As far as the TRT and liver, we already talked about the hepatotoxicity, and that is most commonly with the oral forms of testosterone, and that's why we don't use them. The potential is there for benign and malignant tumors, but it is felt that if a person is on injectable or transdermal preparations, that they don't need any LFT monitoring because of the replacement. Yes? Okay. We'll ignore that. As far as testosterone replacement and sleep apnea, it could develop, having testosterone replacement could help develop sleep apnea or make it worse. Why this happens, I really couldn't uncover, so I'm not sure, but that is something that we just need to be aware of and monitor if someone's on testosterone replacement. Conclusions, and there's a question mark there. All right, and you'll see why as we go through that. All right, so testosterone deficiency syndrome or late onset, adult onset hypogonadism is widespread and undertreated, those that actually would benefit and need it. But yet in some cases, their population is overtreated. And these are the drug seekers that hear about how wonderful it is to party all night, and they're, they may have low T and they want something better. And I have seen certainly less of that in the primary care, because usually when I was in practice, people who would start patients on testosterone replacement without really investigating too much was usually the primary care doctor and not the urologist. But I've seen that less and less. Now I have not, I retired 2 years ago, but I really did not see that much of it at that time. Okay, so the diagnosis is easy, but yet not, and that's because of what I mentioned before, that many of the symptoms are really nonspecific. They're nonspecific enough that even the questionnaires that they have for assessing this are not really that good to take. Does anybody use like the ADAM questionnaire or aging questionnaire to look for testosterone deficiencies or symptoms? Good, because they're not very helpful. Because you may get a positive number on there. Oh, this man is possibly low T, but he's also possibly a number of other things because of the number of differential diagnoses that could lead to all those symptoms. So there are actually few clear contraindications and relatively low risk for treating, yet some providers, even though it has now come out that there is no risk or minimal risk for cardiovascular events, some providers still start their patients on a low-dose aspirin just because they're starting the testosterone replacement. So you can see from that, it's kind of like, okay, well, we've done this, all this, the studies, we've looked at it, we've had all these task force and panels, and we're saying, okay, it's all right, but maybe it's not all right. So you just really have to use a lot of common sense of which patient to put on. Okay. And I went through different policy and white papers, et cetera, from the AUA and the Sexual Medicine Society of North America. And the one that I chose to put here was the one from the Endocrine Society. And this is a task force that looked at everything we talked about here. And they recommend testosterone therapy for men with symptomatic androgen deficiency. All right, so you can read through that and see. My point is, and this is basically everything we talked about, and they give PSA values and hematocrit values and LUTS values, you know, the IPS score. If it's over 19, then don't do it. Again, we saw all this information that says, well, maybe it will help those patients, but we don't have the actual studies out there yet. All right, so the statement here, the white paper, if you will, of this task force was very similar to what the AUA put out and what the Sexual Medicine Society is probably the most enthusiastic about the testosterone replacement, but they're all basically saying the same thing. So that's there, and it says pretty much what they all say. All right, but it says when testosterone is instituted, we suggest aiming for a urogonadal level, okay? So we talked about that. And also, let's see, where was it? Oh, and so they're also saying, now here you can choose on the basis of patient preference, you know, what type of replacement they have, the treatment burden, you know, again, you know, many people wouldn't want to do something that's 3 times a day, and the cost. So you have to consider all these things when you're looking for testosterone replacement. All right, but the important line in this here on this page is when receiving testosterone therapy, patients should be monitored using a standardized plan. Now the plan that is set forth in the AUA and the Endocrine Society is probably pretty similar, you know, but people need to look at that and make sure that they follow that because of the potential for adverse events to occur, even though it's low. So remember, we're not aiming for this, okay? And the not me doesn't mean that it's he saying that. Hopefully it's our patients who are looking into therapy thinking, do I need it for some other reason? No, I don't, so I don't need it. So the whole goal is to make sure our patients realize what the real goals of testosterone therapy are and what the potential side effects are and what the cost burden is as well.